Quickly come up on our time. Dr. Ola, Catherine, June, and John, just want to thank you so much for your fantastic insights today on the power of partnerships and PPP models that can help us strengthen primary care. To the audience, as we look into the next decade and the obstacles that prevent us from achieving
Right, hello and welcome to everybody. Welcome to this panel on legacies in global health, which is part of Africa Health Agenda International. My name is Moki Makura. I'm the Executive Director of Africa No Filter, and I am the moderator for this session. So in the next hour, with the help of my panel, we're going to be talking about who is making the decisions about Africa's health agenda. So a quick reminder to everyone that translation is available in both English and in French. So please click the interpretation button, which is at the bottom of your screen. You choose the language, French, and you mute the original language. So you mute me, speaking English. So this particular conversation really couldn't have come at a better time. Public health is under the spotlight right now, and health systems across the continent are being stretched due to the pandemic. Funders are digging deeper to increase their support to Africa in the middle of their own economic and health crises. African countries have been heavily reliant on foreign aid for many, many years, and donor funds have traditionally made up quite a significant share of the total health expenditure in most African countries. Few African countries have been able to meet the Abuja Declaration to commit 15% of their country's annual budget to the health sector. And nearly 20 years on, only a few countries in the region have reached this target. And most of them are hovering around the 7% mark, which is less than half of what was promised. So who is filling the gap? Well, it's no secret. It's wealthy countries and funders in the global north. And clearly that comes with its own set of issues. For example, decisions about access and allocations of the COVID-19 vaccines in Africa are being made in the global north. So one could argue that he who pays the piper calls the tune, but clearly there is a growing concern about the tune that Africans are being asked to dance to. And it's not just the funding, because when we follow the money, it takes us on a journey up north. According to the 2020 Global Health 50/50 report, 85% of the global organizations active in health and health policy are headquartered in Europe and North America. 2/3 of them in just 3 countries, in Switzerland, UK, and US. And the last time I checked, none of those countries are on this continent. So over the next hour, with the help of a panel of African experts, we are going to unpack global health decision-making. Look, well, we know who is funding global health. We also know where they live, but who is designing the interventions and who is at the table when key decisions are being made? How can global health institutions and funders be more accountable to the people they serve? How can local processes be prioritized? Decision-making shifted closer to where the work is being done and the balance of power equalized. So how do we make sure that both sides, the global north, where the funders sit, and the global south, where the work happens, that these two parties partner more effectively and ultimately learn more from each other? So luckily, I don't have to answer any of those questions because I have a panel of experts who will be unpacking the subject with me. So they'll be helping us understand the legacies of global health and their implications, and sharing some of the new approaches to program design and decision-making that are shaping development today on the continent. But before I introduce the panel, let me quickly remind you to please ask questions and put your comments in the, well, put your comments in the chat feature, but put your questions in the Q&A. It's easier for me to pick them up, and I will be looking through that and asking some of those questions. And also, just so you know, this session is being recorded, so you can always get hold of it after the conference. On that note, let me welcome my 4 panelists. So first of all, I have Dr. Lola Dare, who's the president of an organization called CHESTRAD, which is a global social enterprise, which is focused on sustainable healthcare delivery. Like, Lola is an award-winning community physician. She's an epidemiologist, a public health practitioner, development consultant, entrepreneur, and my favorite, irrepressible global health advocate for women, girls, and young persons. Hello, Dr. Dare.
Hi, everyone. It's great to be here.
Fantastic to have you here. My second panelist is Dr. Enkeichi Olaleri, who's the Executive Director of Strategic Purchasing Africa Resource Center, which luckily has a really cute acronym, SPARK. It's an initiative that empowers countries with knowledge and practical tools to help them access affordable and quality healthcare. So Enkeichi has over 16 years experience in health insurance implementation, and she's the chair of the African Union's Tracker Subcommittee, which is ultimately helping countries track progress on domestic financing. Hello, Dr. Enkeichi Olaleri.
Hello, good to be here.
Okay. Good to have you. My next panelist is Shanaz Munshi, who's a research project manager and an associate lecturer at the Shyham Family Program at Wits University in Johannesburg. Shanaz is a health policy and system researcher. She's an activist, an occupational therapist with over 10 years of experience serving vulnerable communities. She's also the co-founder of African Health Futures, an initiative aimed at reimagining health systems to achieve health equity and social justice, which makes her a great panelist for this particular conversation. Shanaz, hello and welcome.
Hi, thank you so much for having me today.
Great. And we didn't want to ruin the run of fabulous women on this panel, but we've got a man just to balance out the gender inequality here. So Professor Joachim Osir, who's an associate professor at the Amref International University. He is also the technical director of programs at Amref Health Africa. He is a public health, reproductive health, and sexual medicine specialist, and he has contributed immensely to health system strengthening and policy development across Africa. Hello and welcome, Prof.
Thank you.
Right, thank you. So let's get straight to the questions and hear my panelists. I want to start with actually the same question for all the panelists. And I'm going to start with you, Lola. This thing about colonialism, the fact that it ended on the continent over 50 years ago, but apparently we are still enjoying some of that legacy in the global health sector. So I'd love to hear from you that what are some of the legacies you're still experiencing in the way development partners and funders from the global north have historically engaged with Africa?
Thank you very much. We must realize that almost every African health system was built by the colonial, is still colonial, was built colonial. And in spite of the fact that we have political independence, we still don't have an independence from the structures and the systems that we set up. For instance, we have a federation in Nigeria, there's local, state and national government. Our health system is still structured in that way. When our dear friends were with us from the north, the system was structured to take care of the diseases of that the white man doesn't want to catch. And so the priority setting was really about what protects the life of the white man and what protects them from what the things that locals can bring onto him. And that's the way our system is still structured. It's still kind of responding more to the elites, more to the rich, and less to the poor. And that's a colonial legacy we're still dealing with. In addition, the financing of health in Africa was free. It was free from the colonial masters. Our politicians have adopted the concept of free healthcare, which means I get there, I don't need to pay anything, I don't need to prepare my tax, I can get, and I must find healthcare at the health center. That is also very challenging when we don't have the purse of the colonial master. And so our healthcare financing models, our priority setting models, our targeting models still continue to bear the legacy of the colonial master. And that's why to decolonize that global health, we need to have a significant paradigm shift in the way we think. We need to think about our priorities, our people, and not just the people at the top. Like we say in Nigeria, not just the ogas at the top, but that the healthcare system now is needs to respond to everyone. That's the essence of universal health coverage. It's still relatively new, even if it's growing.
Well, there's some interesting things which I think I'd love to unpack later on in the conversation. But let me ask the same question to you, Enkeichi. What's your thinking? What are the legacies that you see in the health system in your work?
Thanks, Noki. I think for me, the very first one is, there's still quite a bit of power imbalance, right? This is really all about the power. In my work, one of the first things that I can really speak to is the definition of who is an expert. It appears that the expert is the person who comes in from the global north, right? And appears to have solutions to the problems that he or she has not experienced. And then the people who are on ground really dealing with these issues on a regular basis, then just become the people who are supported by the experts. So I think that one of the legacies, not a great one, is that definition of who the expert is. And moving into the future, what we really need to see is that people in the global south are the experts in things that are happening with them. And absolutely, we still need support from the global north, but it should be more in terms of allyship, right? Supporting that work, but the real experts are on ground. And then the second thing for me that I see in terms of legacies is the fact that countries get a lot of support, but countries do not get the support that speak to their particular pain points at a particular point in time. Like you said, he who pays the piper appears to dictate the tune. And so funding comes in, but then funding is not really targeted towards the need of the people who are on ground. And even in terms of who provides that support, it also comes from the outside. So this for me is also a very sad legacy and something that needs to change. And at the end of the day, really comes down to the power imbalances that we see today.
Right. No, you make a great point about who's considered an expert. So let's go over to you, Prof. How do you respond? What are the things that you see in your research world around legacies?
Thank you. I think for us to understand the legacy, it's first important to understand the philosophy behind the whole concept of colonialism. The philosophy is that there is a master somewhere and there are subjects, and that the master is more civilized and the subjects need to be helped to civilize themselves, and that the master has a role, a divine role, to help the subjects get civilized. And so in the process, it's also okay if the master gains economically and deprives the subject. This has been called the Darwinian social theory, where you are trying to justify why it is so important for others to benefit by helping to civilize you. Now, in this whole process, the thinking is that the master then knows what the subject needs, that the welfare of the subject can be decided by the master. This is where we are coming from when you think of colonial legacy. And in health, a lot of these things are very obvious. The belief that African health systems should look like those of the West, because the West health systems are better. The belief that someone else outside of Africa knows what Africa needs. You know, the belief that the aid we get from the West should help us make our systems look like those of the West. And if it is not doing that, then that aid is being misused. And that it is fine for Africa to train its health workers and the West to absorb these health workers because there are fewer health workers in the world. And so the West needs them more. This is the economic exploitation part of it. And it is totally fine in the social Darwinian theory. If you think of research, that we can do research in Africa, vaccines have been tested in Africa recently, for example, but that Africans are not the first ones benefit from the benefits of those studies that have been done. This is really the core of legacies and decolonizing health in Africa. If we want to decolonize, then this thinking has to be turned upside down. And we have now to start thinking differently. Thank you.
Right. Well, hopefully we're going to hear some examples of how this thinking is being turned upside down. So Shanaz, let's hear from you on the same question about the kind of legacies that you are experiencing in your world in academia.
Thank you so much for that question. I think the first thing we need to look at is universities in countries across the global south, like in South Africa, many of them are replicas of the universities in the global north. Like we've got Rhodes University in South Africa, which is a replica of Oxford. And often these universities, they carry the knowledge paradigms and the construction of knowledge that stems from the colonial master. So in a way, the knowledge we produce and the ideas we produce, they carry the similar philosophical basis that is somewhat foreign to African people or people of other indigenous knowledge systems. So there's a dominance of a particular type of knowledge system that permeates, and it's extended through language, the dominance of English. It's extended through the ways in which construction of race and gender is perpetuated. And I think it carries out in our solutions and recommendations. And another example from my world is the idea of policies and the way that the North dominates through policy decisions. And an example is the gag rule, which has really been up and down. And it got repealed by Donald Trump, it got put in by Obama, and it's now reinstated. But it really shows us that the global forces have an impact on the lived realities of women, and foreign policy impacts on national policy, and money is then instrumentalized as power, and women on the ground, their lives and their bodies are under the power of the North that decides what decisions they make about their reproductive health and what they can do and can't do. So these are ways in which the legacies still sit with us quite firmly.
Wow, it's quite amazing to hear how far back things go and how we're still seeing some of that stuff in the world today. So Lola, I'm going to come back to you because we are sitting in a unique time, an unprecedented time in the middle of a pandemic. And Africa's response to the pandemic has been, let's say better than most people expected. So what are the learnings from the COVID response that we as a continent can integrate into our health systems right now to help us, to help this power imbalance, because we've had experience that we're not as bad as we think we are. Are there things that you've seen? Are there things that can be integrated?
There's some fantastic things that Africa has done, and we must celebrate that as we look forward to doing even things better. Let me just make a note of a difference. The virus was kind to Africa, much kinder to Africa than it was to our northern partners. It didn't have the same virulence. It didn't have the same pathogenesis. It really behaves differently in Africa. So we must first try to understand why is this virus behaving differently in Africa. It's the same virus, but it didn't have the same elaboration. If it did, we would have the same number of people dying, and so we've been very lucky. But I must congratulate the African CDC. I must congratulate the collective collaboration that we were, for once or for this time, able to come together in Africa to first demand for equity in access to test kits, equity in access to vaccines, equity to ensure that Africa is not left behind. And wonderful, Africa negotiated as a bloc, and we did get vaccines on time. And so rather than me celebrating COVAX, and I do think I celebrate my colleagues in COVAX, they've done a great job of amplifying our voices. I think we must celebrate the African Union and learn from that we can. We can come together and we can do some things excellently together. I think that's one lesson. The other lessons are local. Philanthropy and private sector played a central role in providing resources. Ubuntu, my sisters and brothers, we are our brothers' keepers, and we demonstrated it with COVID. We had soup kitchens. We gave each other PPEs. There was so much of Africa giving back to Africa and philanthropy in Africa, raising its voices for Africa. Mo Ibrahim, Danjuma Foundation. There's so many, and we supported our regional institutions in interesting ways. Can we please continue to do that? Because that's one of the lessons that we take away from here. The infodemic. Okay. The infodemic killed more of Africans than it killed more of the people in developing countries. And so We learned that citizens must be at the center, and we need to provide with them factual information and timely information. Even if some of our herbs work, we need to make sure the information is timely, the information is factual, and we're able to bust myths. And so we were dying more in Africa from the infodemic than we were dying from the virus.
Yeah, and Lola, just to add one thing on that, because I know a lot of research has been done, and research shows that in the countries where there's weak media institutions, that's where the misinformation, the disinformation proliferated. So there's something that's on us as Africans, that we have not supported our media institutions. But I really like what you're saying about Africans demanding equity, and just Africa coming together as one, because it's together we are more powerful than we are as individual countries. So I think that's a huge opportunity and a huge learning for us. But Enkeichi, I'm going to come to you, because you have an example, because the organization you work for, of a situation where it's actually, you know, Africans in a way demanding for equity. It's been built into the program design. Can you tell us about SPARK?
Absolutely, with pleasure. So SPARK actually means Strategic Purchasing Africa Research Center, and like you said, has that very cute acronym, SPARK. And the real business of SPARK is the technical mandate of SPARK is really about the conversation, the foundation that you laid for this conversation, right? The fact that we do not have enough funding for health, right? The fact that donor funds are receding, the fact that physical space in countries are very restricted, and therefore a lot of countries have not been able to meet the 15% of budget declaration. And then add to that COVID, which has further restricted an already contracted space, and we find that we have a problem. And so we had already seen that this is the issue. And so we were saying that while it's important to keep talking about more money for health, but then what's the point of more money if you're going to spend it inefficiently? And that's where the concept of strategic budget comes in, which is the use of information, the efficient use of limited resources to pay for services in such a way that you get the best health outcome for the society. So that's really our technical mandate. But then coming to the topic of this conversation, SPARK is as much about this technical mandate as we are about the approach, how we deliver this technical support. And so at the point that we were scoping for this initiative, we had lots of conversations with different countries, with different African leaders. And they told us something very clearly. They said they wanted a different type of approach to technical assistance, that they no longer wanted briefcase carrying consultants who would essentially copy paste solutions that had worked in other places that have no bearing, no context to the African continent.
And charge a huge amount for it as well.
And charge a huge amount to boot, absolutely. They wanted support that was contextual from people who had understanding of the political economy, people who had relatable experience, people who understood the story of Africa to come in and provide that support. And they added something else. They also wanted this to be sustainable. And so as you provide the support, contextual support, they also wanted this capacity to be left behind in individuals and institutions to ensure that moving forward, they can take that word forward. And so we took this to heart. And so our approach to technical assistance is what we call the coaching approach. And to actually birth that, we convened together with two other initiatives, African experts on the continent that had technical expertise, but then also had complementary soft skills to ensure that these will then become the army to provide support to African countries. And so this was our own way of saying that the expert is actually here. Right. We had a conversation yesterday when one of the country partners said to us that they don't want people coming in from somewhere else and telling them what to do. They know what to do. They only need support to be able to get there, because there are some gaps that you might have in some level of capacity and all of that. But what African countries really need is that person who would walk side by side with them, that person who doesn't come in with preset ideas, already made answers, creating parallel structures, prescriptive, but somebody who will work side by side with partners, gets the work done, and leaves behind lasting capacity. And that this should come from the region. This is inbuilt into our approach, and that's how we provide support for countries. And this is one great way of really decolonizing global health.
Right. Right. And it's working, right? It's working.
It is working. It is.
Fantastic.
Absolutely.
Fantastic. So Prof, I'm going to come to you. A couple of things that Enkeichi said that I quite liked is that they wanted people who understood the story of Africa working on programs for the continent. So I want to ask you, because over the years, countries in the global south have started exercising their autonomy in designing health policies and programs that meet the needs of the people, as Enkeichi has said, and she's given us an example with Spark. So I would love to hear from you, what are the most, I guess, striking examples of countries or health policies where these legacies of global health have been turned on their head? Offer you.
Sorry, yeah. I think Ethiopia has a very good example of primary health care, which has not been tested anywhere else in the world except in Ethiopia. And most African countries are learning from Ethiopia how to do it. A very well-structured community health system.
Prof, I think can anybody else hear him?
It is.
Prof, can I ask you to just start again?
Hear me?
Yeah, because you disappeared for a bit. Can you just start again?
All right, thank you, sorry. Yeah, I was saying Ethiopia has a really good example of a primary healthcare system that involves the community. And I think they have led in showing how this can be done. And a lot of African countries are learning from Ethiopia. This is not something imported from any country in the north. It is a health system cooked in Africa. And I think it tells a story that our health systems do not need to look like those of Europe or America or Canada. We can do it differently here to fit our needs. So I take that as a very good example of how Africa can do it. The second one is in Kenya. You may have heard of the M-Pesa or the mobile money, which is also being used to pay for health insurance. It's being used to reduce COVID infection because people do not have to handle hard cash and transmit money through that, transmit the virus through that. I think Kenya has been leading in mobile money transfers and using mobile money to purchase and including purchasing of health. I think everyone also remembers how Senegal has been able to manage both the Ebola epidemic as well as currently the COVID. And they have done it using their own homegrown solutions. So I think the moment we realize that we actually have solutions that work for our people, that are contextualized, that we do not need to cut and paste things from China or from Japan or from Europe or from America, that is when decolonization of health really starts. And I think those are some of the good examples I can give.
No, that's fantastic to hear. Shanaz, let me come to you because you're someone who works obviously in research and academia. Could you speak to the power dynamics and the biases that play out in the health research or in the course structures or the published articles that you've come across?
Thank you for this question. So, I mean, again, you know, you've brought up that research by nature reflects a kind of asymmetrical power where, you know, the researcher from the outside walks in to kind of a community with the aim to understand phenomenon, draw conclusions and theorize about it. So it comes back to who is the researcher? And again, where is this researcher publishing their findings? And this is where Seyi Abimbola talks about the foreign gaze and this kind of privileging of certain journals where foreign researchers come into African countries, write about communities, and publish for a foreign international audience. But he also goes on to say that sometimes Africans who then adopt this dominant style of knowledge production and knowledge processes are somewhat caught in the trap of writing about local experiences in a similar way for a foreign gaze. So ultimately, the nuance of capturing the African experience is somewhat lost because there are many biases and unconscious prejudices that start to perpetuate and really influence how these things, how knowledge is produced. And what this is called in decolonial theory is epistemic violence, which is the violence that is exerted through knowledge. And it's probably one of the most powerful forms of domination of knowledge is these constructions of these frameworks that legitimize the practices of domination of knowledge. And it really does ask the question for us as Africans is, at what point are we going to develop and design our own journals? What are we going to charge for us to publish? How are the review processes going to work? You know, and how do we then shift which knowledge is more superior and inferior? Because we've got this whole body of African healing, which is somewhat made inferior by the idea that Western knowledge and knowledge that comes out of pharmaceutical companies is more dominant. And the other thing is the money, the idea that there's a dominance of where money goes to which diseases. So you find, you know, the burden of disease in the North is that there are lots of people who are old. And so there's a lot of knowledge going into helping people in old age. Back in the meantime, we are dying of tropical diseases. We are dying of many diseases where there are even known solutions, like TB in South Africa's, you know, phenomenal amount of people die. So there's many questions about knowledge. And I think just to end off on this question, decolonial scholar Sabelo Ndovukacheni has called on us to say that the core of the decolonial project is the agenda of shifting the geography of knowledge and the biography of knowledge. So who generates knowledge? Where is this knowledge generated? And how legitimate do we give these forms of knowledge that come from people who have, through the colonial processes, been othered and been made to feel like they are not really good enough? And I see this often playing out in women. We don't feel smart enough. We don't feel like we can be knowledge holders. It's very intimidating to be on panels even. So these things are really, it really comes back to how confident are we that we can come and we can say that I can reclaim the knowledge I have as my own.
Yeah, no, thank you. I do have to say, I don't think any of the women on this panel are in the slightest bit intimidated at all. But what I do want to just push back a little bit is that, you know, you talked about this shifting of geography and biography of knowledge. What's stopping us? What is stopping us as Africans publishing about the, you know, like COVID organics, for example? That just, you know, seemed to just, everybody was laughing about that, on, you know. What's stopping us talking about it and publishing, and what's stopping us putting our own journals out there?
I think part of it is this kind of the capacity building. Do we have enough capacity to conduct research? And again, certain types of research are more dominant than others. So you find if you are do a cluster randomized control trial with a big, large sums of money that require lots of resources to conduct the research, you know, versus qualitative research that really gets into the nuances. So it's a question of money. Do we have money to do the research? And I think there's many things, and then the language barrier again that I mentioned earlier. So often you need to publish in English, and if you don't have your good command of English, you won't be able to write in a particular academic format. There's many barriers, and many of these barriers are really insidious, and they subtle. So it often, and again, I mean, just to go back to the idea that these universities that you're supposed to get ethical approval for the knowledge are hard to get into. So you need to have tertiary education, you need to be a particular type of knowledge person that, you know, and often it's probably middle-class Africans who are again writing about poorer Africans who they don't have a lived experience over, and fall into that same trap of writing about those that are voiceless, you know, and so we fall into a lot of these traps, and it's difficult to come out of it. But I think intentionally we need to start understanding these dynamics, so conversations like this help, and then we need to start addressing them through coming together and developing a kind of African epistemological project that starts to shift and allow those who are experts of their own lives and lived experiences, those on the ground, to be very integral to the research production processes, to be integral to setting the research question, to conducting the research design, to validating the results that are drawn about them, and also to presenting these research findings at conferences. Yeah, those are some ways, but I'm pretty sure there's many others. Yeah.
Right. Enkeichi, you were going to add to that?
Yes, absolutely. Nobody can tell the African story but the African, to be honest. And so we really need to start focusing on that. And I hear you, Shinaz, but you know, my take on this also is the fact that sometimes perfection is the enemy of done. One of the things that we have done with at Spark is to ensure that we have a technical consortium, about 11 academic institutions spread across Anglophone and Francophone Africa. And what we're doing with them is really to have them document. So these are academic institutions, and of course they will have that rigor, to document the experiences in strategic purchasing that we're seeing. And so we then begin to tell that story ourselves. Now, as they continue to do that work, we have also seen the need to further reinforce that work. And so one of the things that we're working on now is to also set up a technical review panel that would work with these institutions, just to make sure that, not just for the rigor, because these are academic institutions, they have that, but that the final output is really great and can meet any international standards. But to be honest, I would really prefer to read a badly written in English language story told by an African, because it captures the nuances. I mean, there was something that I saw on the internet a while ago, and it was somebody really speaking to the fact that a study was carried out in an African country by people from the global north without actually even attributing anything to the partners on ground. Where did you get your information? What do you know about it? So some of the nuances, those contextualized things, are lost in that translation. Africans need to tell their stories, and we need to be able to provide that support. We're trying to do that also at Spark by having this technical review panel, by having the technical consortium tell the story, but it starts from somewhere, and we need to tell that story.
Right. No, you make an excellent point about Africans needing to tell their own stories. But I think a big part of our ability to tell our story and understand our story is understanding the data, is having data. So Lola, I'm going to come back to you, because one of the areas that I feel that is often lacking in a lot of African countries is just good data about their own numbers, their own health systems. So is there anything that, you know, we can do to sort of disrupt healthcare systems through better use of data, Lola?
It is absolutely spot on that until when the hunter tells the story, he's always victorious. And so many times we have left the storytelling to the hunter, and in this case, our development partners, in which case they've told the story to our grandfathers and they're still telling it to our children. And so we need to look for ways of using convincing data to support our passion as we tell our stories. So data use also needs to be decolonized. Many of our ministries of health collect the data and report to WHO, report to UNICEF, report to, sometimes when you ask them when they've done what they've done with the data, they say, oh, we reported it to WHO. And so data is a transformative lever in itself, and using data and providing access to data is a very, very important thing. We work on a project called BIG, Better Use, Improved Action, and Good Data. Data will be good, We communicate this data with our communities in colors. In Africa, everybody knows red is danger, green is good, and yellow is be careful. And so we can actually engage communities by using data visuals. And we are at a crossroad where technology allows us to use data in visuals, in animation, in creative ways, and oftentimes many of it is free. And so I'm so fascinated by technology and the internet and the capacity to get our message to whoever and wherever we want to get it, by using Twitter, by using social media, and also by ensuring that we use the colors and images of Africa to translate the data. For instance, we were very successful on some campaign that I think we should not be mentioning here, but we changed the direction in the North from going in one direction by just using the power of colors, our people, and social media. So it's very, very important for us to use data. Data also, beyond being a lever, data is also a credibility lever. We must stop thinking that our moral persuasion is enough to shift what's been entrenched over many years. We are passionate about Africa. We love Africa. We live Africa. But we need to have the moral courage to use information to shift the dial. And that, in this regard, I'll be talking to us as Africans. We need to shift our heads from what Enkeichi has mentioned. Who is the expert? Enkeichi, thank you. You are the expert as far as I'm concerned. And I would continue to look for the Joachims, the Shinars, and there's so many other people who are experts. Number three, we can use data in a novel way to also build South-South collaboration and share our information South-South. In that regard, I'd like to mention the current work done by the AU, the WHO Africa office, and the development aid countries, the D8 countries on health and social protection, are using data visuals to share among these countries, and these countries are evolving their own response to HIV, to COVID response. So data is a very important lever. But as we use data, we must also pick up what, I'd like to pick up what Joachim, I think, has said. How do we train our health workers? Sometimes we're training them for export. We're not training them for domestic utilization. And so we've paid so much emphasis on those priorities that get them out of the continent, rather than those passionate things that keep them in the continent. So how do we train our health workers? Are we training them only thinking that specialist care at that level is what makes you a physician or makes you successful? And we need to look at how we train our health workers, use data to train them, use our own reality and our own context to train them. And we need a different discussion and a different narrative. I must close that by saying there's an Oba Oni of Ife, who once said to us, come back with me with the African narrative, and the Africans will dance with you in an orchestra. Thank you.
Thank you for that. So Prof, let me ask you, the work that you see, because you are in a academic environment, we see how researchers and funders and universities from high-income countries, they are the ones with the funding, so they're dominating the global health research agenda. Do you see consequences of these dynamics? The fact that a lot of research, for example, is done in South Africa because everybody talks about this incredible, this research capability, good infrastructure and really smart people, researchers, but they are not researching the issues that are relevant to South Africa because the money is coming from somewhere else and they're concerned about other things. Is that an issue? Is there a consequence to this, Prof?
Yes, there is a consequence. First, you will realize that most of the big organizations that fund research are not headquartered in Africa. And that money, how it will be used is decided outside of Africa. And so one other thing is that when you say $1 million is going to be used for research in Africa, a lot of it will remain in the north or wherever the money is coming from, because the overheads are managed from there. To the extent that sometimes the amount of money that reaches the ground could be 30% of what was intended. A lot of it is lost along the way because we are managing it from elsewhere. The other thing is now we have a situation where we are even exporting our experts to be the headquarters of those organizations. And if you can think like an American or like a British, then you are allowed to then work there and decide for Africa. In other words, you know, the French policy of assimilation during colonialism, where we take you and convert you into a Frenchman, and then you can come back and show Africans what to do. That is very much there. So once these people have been assimilated and they think differently from how we think in Africa, then they can decide on the research and even do it in places where it is easier to do it. So in South Africa, where there is infrastructure, but not in Somalia or DR Congo or in South Sudan, where life is difficult. Now, if we were to do it differently, there is a lot of research needed in Sudan, South Sudan, in Somalia, in parts of Kenya which are unreachable, that could transform health in Africa. You know, the bad health indicators, if you come into a country, you find there is a lot of disparities in health indicators depending on which part of the country you are in. So if you are in Kenya, for example, Nairobi is very different from the border of Somalia and Kenya. There are towns in that side. The health indicators are very different. The needs are not in Nairobi. They are in those places which are hard to reach. And so if you are deciding to do research in Africa, those are the places that need that research. How can we transform health in these difficult places and improve the health indicators? But if you're making these decisions in the north and in places where you're seeing Africa in a different way, you will not reach those difficult places. And I think this is one reason why our indicators are failing to change. But finally, just to go back to the issue of disseminating data and publishing, I think, again, there is a colonial legacy around this, that you must publish in the British Journal of Medical Sciences, in the American Journal of Health Sciences, you know, then that is important. I mean, if we did music and art in Africa because we do it so well, we would still pass the same information. And now, with social media and ability to do videos, we can narrate our story, and it will be an interesting story to listen to. Say, I mean, how many people read the British Journal of Health Sciences, of obstetrics and gynecology? How many Kenyans are able to even access those, because they are sold? Once you publish there, then you have to buy to read it again. And Africans cannot afford to buy all those publications to be able to read their own studies and use it for health policy and for health development. I think it's really a mind shift that is needed to correct things the way we do them here.
Yeah, I think you're absolutely spot on about a mind shift in a lot of ways. But now I'm going to go to a couple of questions that we've had from the audience. This one is from Pius Mutu, and I'm going to read it out. And then I think, Lola, you might be the best placed person to answer this one. But the question is, part of the legacy from colonial times is distrust for the system. For consumers to commit to paying for health services, they must be able to trust the care and services they receive. How can this be achieved in local communities in Africa? Lola, is this something you can answer?
That's so true. One of the challenges we have with the COVID process is distrust of the politicians, the distrust of, and that distrust is built and ingrained over many years. So yes, it's time we need to begin to punch and do something about the distrust, not even just for the system, the distrust we have for each other. If you are walking across the African Union, the person in the East doesn't trust the person in the West, doesn't trust the person in the North. And so sometimes it's a challenge for us to come together. But we are already beginning to punch that distrust. One of the ways to punch that distrust is to be accountable and to ensure that there's not only accountability supply when you supply the report and nobody questions the report, We also need to build capacity of non-state institutions and indeed the courage of non-state institutions for accountability demand. Most people have moved away from accountability demand for remedial, for sanctions, because the next meal is coming from the next grant. And sometimes it means that the people no longer trust us to be their voices because we're not also engaging in accountability demand. I think the accountability demand must match accountability supply for people to begin to trust us. Another lever for building public trust is data. It's really data. The more people believe in the data, the more the data is shared, the more people democratize and have freedom of access, not just to information, but to data bills in our country, the more it's easier for them to trust what we say, and we need to build public trust. Finally, we need to look at African leadership. African leadership. I have often wondered why the piper should dictate the tune. It's the dancer that should dance to the tune he likes to dance to. And so I think we should also punch the story of some piper from somewhere telling me how to move and wave my hips. Nobody has ever told us how to do that. They must look at my hips and play the music I like to dance to, otherwise I shall refuse to dance. The piper must no longer dictate the tune. However, we are not a world on our own. We need to work with the others at the same time. So can I suggest that we build an orchestra and dictate the tune that we dance to together? I think the piper must no longer dictate the tune. That is also a mechanism for building public trust and building public confidence that we can do it together.
Right, that's fantastic. I love the analogy. And, you know, to Prof's point about a mind shift needed, it seems as if we equally need a mind shift with our leaders as well. So it's not just us. Another question, this one was put in the chat, and it says, are journals the only way of propagating public health knowledge? What other ways could we develop? So that would either be for Prof or Shanaz. Do either of you want to take that? Are journals the only way of propagating public health knowledge? And while Prof or Shanaz is thinking about that, can I ask, you know, we've still got a few more minutes. Can people put questions in? I think this is a fascinating conversation and love to hear more from the audience. So please put your questions in the Q&A or the chat. Prof.
Yeah, I mean, as I said earlier, journals are even limiting what we are able to achieve from those studies published. Because once we go for prestigious journals, and once you publish there, nobody can access it unless they buy that paper. And so it becomes unavailable for local readership. It does not help in changing health programming and policy. Our stories can be told differently. If you write blogs as well. But Africans had ways of passing their messages, and we can revive those ways. If I was talking to a president or a minister, they're likely to listen to my music and resonate with it and get the message than if I give them a very technical paper that I have published. So how we communicate needs to change, and we need to utilize channels that are more easy to use for our people to utilize that information.
But Shanaz, can I just ask on that? I mean, as a non-academic, you know, publishing papers in certain types of journals, is the purpose of that is to get the story out, but it's also hopefully for it to lead to some sort of intervention and you know, a rollout of the solution. So surely, so I'm just trying to figure out the purpose of publishing, you know, because that seems to be the thing, the aspiration for everybody. Why, I guess, is my question. Why are we in such a hurry to publish if we really just are looking for the solution?
Thank you so much for that question. I think it answers your earlier question as well, because I think once you're in the academic world, which I now, from being a practitioner, occupational therapist, to now trying to navigate the academic world, for me to move forward in my career, I need to publish a lot. So the incentives to publish relate directly to my career growth. So this idea of publish or perish is a dominant theme. So unless you publish a lot and unless you write, the quality of it is compromised. Sometimes the narrative is compromised because one is looking out for our own interest. And again, I feel that this falls into the colonial trap of this individual system, which comes from the philosophy of Descartes, which is I think, therefore I am. But if we have to take a paradigm shift, and we have to do what Dr. Lola asked us right at the beginning of this conversation, to come together, to think about philosophies that emerge from the African continent of Ubuntu, then perhaps the whole paradigm of knowledge will completely be transformed. And perhaps we will publish not to progress in careers or to try to be the expert or the professor or the whatever, but to really take the ideas, to translate the ideas into solutions that can really transform and bridge the inequalities that exist, and these very deep, stubborn inequalities. And I think this is what we are trying to do in the African Health Futures Project, is to shift the paradigm. And what we've done is we actually wrote a blog calling Global Health and the Current Systems of Knowledge, drawing on Audre Lorde. We called it the Master's House. So Audre Lorde says that you cannot dismantle the master's house with the master's tools. I've shifted that around. So we're saying that perhaps, Audre Lorde says that perhaps for the master's tools, we may need to actually find tools of resistance and building that come from somewhere outside of the current project, outside of the Western canon, outside of mainstream media, outside of political institutions, perhaps outside of history altogether. And when we look at what's been written, this whole conversation, there's a lot of references to idioms, to dance, to song, to the ways in which knowledge is translated when we sit around having a meal as Africans, when we listen to a song, you know, like Fela Kuti talks about Teach Me No Nonsense, or the Malian artist Fatoumata Diawara, she translates a lot of ideas around female genital mutilation and the experiences of women through songs. So these things are already happening. I think that we need to shift our lens to see that Africans are producing different types of knowledge. And in fact, we need to say that research in journals are not the only forms of knowledge, but actually let's elevate the status of African ways of knowledge production. And let's build our consciousness to how Africans do things and validate these forms of knowledge, you know. And I think those are some of the ways we can really turn away from the hegemonic practices to then look at ourselves and reclaim our identity and reclaim our status as knowledge producers and experts of our own lives that have a story to tell. Thank you.
Right, okay. Thanks.
Can I just quickly
Go
jump
ahead.
on that? I think, yes, we have to tell our own stories. And Professor Joachim, I would like to challenge the research community to actually understand how Africa listens. Africa does not listen by reading. Africa listens through storytelling, moonlight stories. So is it possible for us, for our research to be distilled into stories? 2, Africa listens in songs. We are still listening in songs. So many of our young people have followed the Davidos, the Wizkids, the Naira Marleys, the Burna Boys, and all over Africa, they sing something, and even sometimes I dance too, even if I don't want them to see my children to see me dancing. So Africa listens to stories, Africa listens to songs, and Africa also listens through word of mouth. Are there opportunities for us to distill the key research findings, working with the media, working with the entertainment industry, to distill Africa's stories and Africa's progress, especially in social sciences, through this media?
I think it's a fantastic idea. I think it's a great idea, and I think it's a subject for another conversation. We've got a minute left, so I want to go around and ask each of you one final closing question, and to keep it short because we don't have much time. But what is the one change you want to see to dismantle the power imbalances we were talking about? And what would good look like? What does a good partnership with the Global North look like? So let me start with Enkeichi. Let's start with you, and then to Lola, and then Prof and Shanaz.
That's a great question. For me, it's the one thing. It's redefining who the expert is. The expert is
Right.
not just the person who comes in from the global north, it's also the
Right.
person who is here doing that work in the global south. What we need from the global north is allyship, but the expertise also already exists here.
Fantastic. Prof.
Yeah, thank you. I think we need to step back and ask ourselves, why are things the way they are? And as we've said, we need a mind shift. We need to find out why is it we do the things we do and see whether it is really because of the colonialism mentality that we've developed over the years. And so
Right.
it's a point for self-reflection, and we need more discussion on this issue.
Thank you, Prof. Shanaz, and then Lola.
Thank you. For me, the one thing that we need to do is we need to start a deep practice of reflexivity, which is really examining how we ourselves as Africans, in our ways of being, our ways of doing, our ways of relating to others, we perpetuate the colonial systems of oppression and we exploitation and discrimination. And we need to take an intersectional lens, and we need to start shifting how these power dynamics occur, but taking a reflexivity lens and really turning the mirror and looking at ourselves is where it needs to start. Thank you.
Thank you. And Lola, what's your final word?
I think the way forward is for us to redefine solidarity such that it is value-based and not just driven by economy and military power. Deconstructing solidarity would mean that we give more value to our narratives, our experts, our processes, our priority setting, our decision-making process, and then we can reconstruct a new way of working together. So I think it's redefining solidarity in ways that tell our stories the way we see them and the way we want them heard.
Fantastic. So, well, I think this has been a really interesting panel for me. And I think one of the big insights for me personally is just the fact that the way the health system in Africa was built, in that they're built to actually replicate the global north. It was built not for us. And I think just that realization, that means that we can change it. And that speaks to the mindset shift, which Prof was speaking about. I think everybody on this panel is playing a role in I guess, decolonizing global health. And I think that's what we want to see, that there is a way that we can go, and it's not that hard. It actually starts with us, and it goes to the music analogy. And I love the way you framed it. I've never heard a dancer dancing. The music must follow the dancer, not the other way around. But on that note, I want to thank my panel. So to Dr. Enkeichi Olaleri, thank you. To Dr. Lola Adare, thank you. To Professor Hakeem Hosea, thank you. To Shanaz Munshi, thank you very much for joining this panel. And thank you to the audience for your questions and for your interactions.
Thank you very much for having us.
Thank you so much.
Thank you.
Thank you. It was a great session.